Picture a mother in a village in Uttar Pradesh in 1955. Her child has a form of tuberculosis that is entirely treatable with existing medicine. The drug she needs is physically available. It is sitting on a shelf in a pharmacy in the nearest town. The barrier to saving her child isn't a lack of supply or a failure of logistics. It is purely financial. A single month of treatment costs more than her family earns in half a year. This price is set by a foreign corporation. They hold the patent, manufacture the drug abroad, and ship it into India with no local competition to drive costs. She cannot afford the medicine, and her child dies. This specific scenario repeated millions of times across the newly independent nation. While the science to cure these diseases existed, foreign-owned patents created a price gap that the average citizen could not cross. This forced the Indian government to decide whose interests it would prioritize, international patent holders or the survival of its people. In 1947, India achieved political independence, but its pharmaceutical market remained a colonial relic. The systems established under British rule kept the country dependent on imported Western medicines. Western multinationals controlled 90%. In 1957, the government appointed Justice N. Rajagopala Ayyangar to examine the patent system. Ayyangar was a methodical legal mind who viewed the current regime through the lens of public health rather than corporate profit. For 2 years, he cross-referenced data from doctors, economists, and hospital administrators to map the actual impact of patent laws on the ground. He found that Western corporations used patents primarily to maintain high prices and block local competition. Ayyangar's analysis showed that the existing patent regime functioned as a mechanism for pricing monopolies that drained capital from the country while leaving diseases untreated. Ayyangar focused on the product patent. This grants a company exclusive ownership of a drug molecule for 20 years. Under this rule, no other manufacturer can legally produce it, allowing the patent holder to set prices at whatever the market can bear. Ayyangar's 1959 report proposed a radical shift. India should only recognize process patents. This protects the recipe, not the molecule itself. A chemist can legally reverse engineer an entirely different chemical route to create the exact same medicine. This would allow Indian companies to invent their own manufacturing methods for Western drugs and sell them at a fraction of the original price. This report provided the technical blueprint for dismantling a global monopoly while remaining within the letter of the law. The report sat in government files for a decade as the political class hesitated. That caution ended in 1966 when Indira Gandhi became prime minister. Gandhi held a deep skepticism of multinational pharmaceutical interests. She argued that these companies were generating excessive profits from life-saving treatments that most of the world couldn't afford. In 1981, she challenged the global health establishment directly at a summit in Geneva, calling for a world where medical discoveries would be free of the patents that restricted their use. Gandhi provided the political mandate to implement Ayyangar's legal theory, giving the government the weight required to challenge the world's most powerful pharmaceutical corporations. In 1970, India passed the Patents Act. It formally abolished product patents for drugs and shortened process patents to just 7 years. The act dismantled the legal barriers to domestic production, allowing Indian companies to begin competing on a massive scale. But the change in law was only the beginning. It gave Indian companies the permission to copy these medicines, but they still lacked the technical knowledge to do it. To realize the vision of medical sovereignty, thousands of Indian scientists now had to enter their laboratories and figure out how to rebuild these complex molecules from scratch. In 1970, India was a nation of over 500 million people, yet 90% of its pharmaceutical supply arrived from abroad. Multinational corporations held the patents on almost every major drug. By controlling the legal ownership of these molecules, they dictated prices that were entirely out of reach for the vast majority of the Indian population. The human cost was a series of preventable tragedies. Children died from tuberculosis and malaria because their parents couldn't afford the same treatments that were widely available in the West. Global medical science had already found the cures, but a legal wall severed the connection between the pharmacy and the patients who needed it most. To ensure its own survival, India embraced a grueling, controversial form of scientific intervention. Reverse engineering saved more human lives in the 20th century than almost any other scientific discipline. It begins with a finished, commercially sold pill. Chemists dissolve the tablet and run it through analytical instruments, mass spectrometers and chromatographs, to decode its exact chemical makeup. They map the active molecule's precise bonds. But the real challenge is finding a completely different sequence of chemical reactions to build that same molecule from scratch. By using unpatented starting materials, you reach the identical destination by a legally distinct road you built yourself. This discipline required Indian scientists to map an entirely new way forward for a global pharmaceutical market that had been closed to them by law. The 1970 Patents Act acted as the starting gun for this transition. By recognizing only the process of making a drug and not the drug itself, the government legally enabled Indian chemists to begin their work. This timeline shows how quickly their capabilities accelerated. When ibuprofen was introduced globally in 1967, it took Indian scientists 6 years to produce their own generic version. By 1986, the gap for the antibiotic ciprofloxacin had shrunk to just 3 years. As production increased, prices fell by up to 80%. Antibiotics that once cost 50 rupees dropped to 5. Tuberculosis drugs that cost hundreds fell to tens. In 50 years, the country transformed its entire medical economy. India went from being 90% dependent on foreign imports to meeting 95% of its domestic drug needs internally. This self-sufficiency became the first great dividend of the Patents Act, making life-saving medicine affordable for millions of people for the first time. These statistics were built by scientists working in poorly equipped government-owned laboratories. They were solving chemical puzzles that their Western counterparts never had to face. Western companies had teams of hundreds and massive budgets. Indian chemists worked with minimal equipment and the thin margins of a generic drug industry. In the early 1980s, one team spent 18 months trying to synthesize a single European antibiotic. They faced a year and a half of failed attempts and batches that degraded before they could even be used. Every failure in the lab carried a human cost. The team knew this drug was keeping children alive in Europe while remaining entirely unaffordable for families in India. When they finally achieved a clean, reproducible synthesis, the team leader reportedly sat down and cried. He understood concretely what that successful formula would mean for the patients waiting for it. The industry grew out of this specific scientific fury. While the profit margins were low, the motivation was a desire to dismantle the injustice of expensive medicine in a poor country. The grueling lab work of the 70s and 80s created the foundation for global giants like Sun Pharma and Dr. Reddy's. To fuel this growth, India built a massive infrastructure for active pharmaceutical ingredients, the raw chemical molecules that serve as the building blocks for finished drugs. India stopped just making pills and constructed entire industrial zones. They took control of the entire supply chain, from the initial chemical synthesis to the final global export routes. By the year 2000, India had become the third largest producer of pharmaceuticals by volume, supplying medicines to over 100 countries. The chemists who had mastered these complex synthesis pathways had successfully provided a lifeline for the entire developing world. But after 30 years of mastering this system, the environment was about to shift. In 2001, one man with a single phone call changed the mechanics of global drug access. It is late at night, February 6, 2001. A quiet dinner party in Mumbai is interrupted by a ringing phone. Dr. Yusuf Hamied picks up. On the other end is Donald McNeil Jr., a reporter from the New York Times, calling to verify a tip. McNeil tells him a story is about to run on the front page. Tomorrow morning, the world will learn about a fax Hamied sent 3 weeks prior, offering a 3-drug AIDS cocktail for $1 a day. That brief confirmation ignited a legal and economic standoff between a single Indian lab and the world's largest pharmaceutical conglomerates. It set the stage for a global debate over whether medical patents should take priority over a continent's survival. At that exact moment, across sub-Saharan Africa, HIV and AIDS were killing an estimated 8,000 people every single day. Not globally, in Africa alone. The death toll had already surpassed both world wars combined, creating 14 million orphans. The tragic irony was that a highly effective treatment already existed. Since 1996, antiretroviral therapy, a combination of drugs that suppressed the virus, had caused AIDS death rates in the United States and Europe to collapse by over 70%. This chart shows the economic reality of 2001. Western pharmaceutical companies, holding the patents, priced the life-saving cocktail between $10,000 and $15,000 per patient per year. Meanwhile, the average annual income in sub-Saharan Africa was around $500. Only 4,000 people on a continent of hundreds of millions could access treatment. The drug supply was plentiful. The barrier was entirely a corporate price tag. Yusuf Hamied was uniquely equipped to challenge this system. He was a brilliant, Cambridge-educated chemist with a mercurial streak, deeply uncomfortable accepting the status quo when the stakes were human lives. Hamied's philosophy was woven into his company, Cipla. His father founded the firm in 1935 alongside Mahatma Gandhi, built on a nationalist vision of Indian self-reliance and affordable medicine. By the 1990s, the disease had earned Mumbai the grim nickname AIDS capital of India. In response, Cipla turned its massive manufacturing capabilities toward the crisis, successfully synthesizing the components of the vital three-drug cocktail. Operating outside the Western patent framework allowed Cipla to treat the AIDS crisis as a technical manufacturing challenge rather than a legal obstacle. In late 2000, American activist William Haddad approached Hamied with a direct challenge. Could Cipla combine the ingredients and produce the full AIDS drug cocktail for exactly $1 a day per patient? Hamied ran the numbers. The margins were incredibly tight. To hit that target, Cipla would have to operate at cost, and possibly even take a loss on certain chemical components. This visualization shows the result. The math worked out. The final calculation brought the total cost down to $350 per patient for a full year of treatment. In January 2001, Hamied drafted the offer and sent a fax to the international charity Médecins Sans Frontières, officially committing to the price point. That single page of calculations became a weapon. By proving the drugs could be manufactured for a fraction of what Western companies charged, Hamied stripped away the illusion that $15,000 was a necessary price. The Western pharmaceutical industry launched an immediate, aggressive counterattack. GlaxoSmithKline's CEO publicly dismissed Cipla and other generic manufacturers, declaring, "They are pirates. They have never done a day of research in their lives." The U.S. government threw its weight behind the pharmaceutical giants. The Bush administration's trade representative threatened severe economic sanctions against any country that dared to issue compulsory licenses to import the cheaper AIDS drugs. The conflict culminated when 39 major pharmaceutical corporations joined forces to file a massive lawsuit against the South African government, legally attempting to block them from importing the life-saving generic medicines. By suing a sovereign nation to prevent it from keeping its own citizens alive, the pharmaceutical industry overplayed its hand. Their defense of intellectual property put the sheer cruelty of their profit margins on global display. The lawsuit sparked international outrage. Activists flooded the streets outside pharmaceutical headquarters, brandishing signs that explicitly linked the company's pricing models to the mounting death toll. Critics accused Hamied of exploiting the crisis merely to grab market share for Cipla. His response was blunt. "Of course I have an ulterior motive. Before I die, I want to do some good." The public pressure became entirely unsustainable. In April 2001, the cartel of 39 companies completely surrendered, withdrawing their lawsuit against South Africa. This graph tracks the long-term impact of that surrender. The cost per patient per year has plummeted from $15,000 to less than $100 in many nations today. Consequently, India now produces 92% of the world's antiretroviral drugs, delivering life-saving treatment to more than 6 million people. Hamied's Defiance dismantled the financial blockade surrounding AIDS treatment, ensuring patent prices were no longer the primary factor in whether millions lived or died. New Delhi, 2006. A heavy silence settles over a crowded courtroom, marking the beginning of an unprecedented legal confrontation. Inside, a lawyer is arguing for something rarely heard in an Indian court: the legal right of an entire nation to access medicine at prices that wouldn't kill the patient. The case is Novartis AG versus Union of India. At its center is a single cancer drug, and a verdict that will decide the fate of India's ability to manufacture affordable medicine. If the court rules against the government, millions of poor patients across the developing world will lose their supply of life-saving medicine. To understand how India ended up in this legal crosshair, we have to look back at the ticking clock of 2005. That year, India was forced to fully comply with the World Trade Organization's TRIPS agreement. TRIPS mandated that member nations enforce Western-style product patents. These were the exact types of corporate monopolies the Indian government had deliberately abolished back in 1970 to keep healthcare affordable. If lawmakers simply copied the US or European patent systems, India's generic manufacturers would be legally blocked from producing any new medications. Without this competition, an essential medicine costing $365 a year would instantly skyrocket back into a $15,000 a year luxury. India had to comply with the WTO, but the government made a calculated decision. They would write the rules of that compliance on their own terms. Their target was a pharmaceutical practice known as evergreening, a corporate loophole that allows drug companies to artificially extend their 20-year monopolies for decades. The practice works like this. Pharmaceutical companies make minor, clinically insignificant changes to an existing drug, like introducing a new salt form, a new dosage, or a new delivery mechanism, and then file for an entirely new patent on the medication, effectively resetting the 20-year clock without producing any meaningful medical benefit. To stop this practice, India designed a highly targeted legal countermeasure, Section 3D of the amended 2005 Patents Act. Section 3D explicitly required that any new version of a known drug had to prove a significant enhancement in therapeutic efficacy. Better absorption wasn't enough. It had to actually work better as a medicine. With that single clause, India engineered a legal kill switch that outlawed the Western industry's favorite monopoly tactic overnight. The ultimate test of this law arrived with Gleevec, made by the Swiss giant Novartis. Gleevec was a genuine medical breakthrough that turned a fatal form of blood cancer into a manageable condition. But Novartis tried to patent a slightly modified salt form of the drug in India. The patent controller reviewed the filing and rejected the application, stating it completely failed the Section 3D efficacy test. The branded version of Gleevec cost patients approximately $2,600 every single month. Meanwhile, Indian manufacturers were producing the exact same generic treatment for just $17 a month. In a region where many patients live on a few dollars a day, the 150-fold gap between those two numbers represents the literal distance between starting treatment and being left to die. Novartis appealed the rejection, sparking a grueling 7-year legal battle that went all the way to the Supreme Court, as global public health organizations watched with anxiety. Finally, on April 1, 2013, the Supreme Court ruled firmly against Novartis, denying the patent and fully upholding Section 3D. The ruling proved that a national court could successfully prioritize human life over a multinational corporation's legal strategy. The ripple effect of that single verdict protected medicine supply lines for millions of people across Africa, Southeast Asia, and Latin America. By outsmarting Big Pharma in court, India protected the legal framework that allows its generic industry to flourish, ensuring that affordable versions of life-saving drugs remain available to the developing world.
Keep a global supply chain of vital medicines alive, and you're going to need sterile stainless steel, deep cold storage, and machines capable of filling thousands of glass vials every single minute. But if you trace the supply chain of those vials all the way back to 1966, you end up standing in the dirt of an Indian horse farm. Cyrus Poonawalla was running his family's equestrian business in Pune. He bred racehorses, and he was highly successful at it. Outside the gates of his farm, a newly independent India was struggling with a chronic shortage of imported vaccines. Diseases like polio and tetanus were spreading through the population, and the imported medicine to stop them was priced entirely out of reach for a country of 500 million people. Back then, vaccines were manufactured using serum, blood products derived from animals. Poonawalla realized his farm already had the biological infrastructure to produce those precursors. He stopped breeding champions for the track and started extracting antitoxins. He built the Serum Institute of India.
By abandoning luxury animal breeding for cheap human medicine, a single local farm laid the groundwork for an industrial powerhouse that would eventually blanket the globe. Through the 1970s and 80s, the Serum Institute relentlessly scaled its production of childhood vaccines. By the 1990s, they had achieved absolute dominance in manufacturing volume. This massive pie chart illustrates the global reliance on that single facility by 2017. At 21 years old, he became the heir to the most expansive biological production line ever constructed. This created an invisible, terrifying vulnerability. The world had unconsciously outsourced the immune systems of its youngest citizens to one family. If anything disrupted Pune, the global supply would instantly choke. In January 2020, as the first global lockdowns took effect, Ayyangar Poonawalla looked at a new coronavirus vaccine candidate from Oxford and AstraZeneca. He made a decision to begin manufacturing millions of doses of this specific formula. It had not completed clinical trials. It had zero regulatory approval. This split timeline Gantt chart shows why he took the risk. The top bar maps the standard process. Wait months for regulatory safety approval, then start manufacturing, leaving the world completely exposed. The bottom bar shows Ayyangar's strategy: overlap production with the active trials. Following that bottom timeline to its end reveals a massive financial fork. If the trials succeed, the green path shows global supply ready on day one. But if the trials fail, the red path means Poonawalla has manufactured hundreds of millions of dollars of biological waste, risking his personal financial ruin. He ordered the production anyway. As he later put it to Time magazine, "If we don't do it, who will?" By December 2020, the gamble paid off. The vaccine received emergency authorization, and the international COVAX program based its global rollout almost entirely on Puna's promise to deliver 1.1 billion affordable doses. Then came April 2021. India was struck by a devastating second wave of the virus, and the daily death counts exploded. Domestic hospitals collapsed. With essential supplies like oxygen running out, the Indian government clamped down on exports, instantly redirecting all of Serum's global vaccine stock to fight the local emergency. Desperate politicians and powerful domestic figures began directing aggression and threats at Ayyangar Poonawalla. The pressure became so intense that the 40-year-old CEO temporarily fled India for the United Kingdom. The vulnerability built over decades was finally exposed. When dozens of African and developing nations realized their expected shipments were locked inside India, immunization programs froze. A local health crisis had triggered an international paralysis. Ayyangar returned to India in June. As the second wave slowly receded, the massive domestic manufacturing engine accelerated. By the end of 2021, India had delivered more than 1 billion doses domestically, and the Serum Institute finally managed to restore its export lines to 170 struggling nations. Today, the Serum Institute has expanded its operations to a staggering output capacity of 4 billion doses per year. Cyrus Poonawalla, the man who started it all, currently stands as one of the wealthiest individuals in Asia. Looking back at his original family business, the racehorses clearly had a good run, but the vaccines ran further. The immense wealth the Poonawalla family accumulated is secondary to what they actually built: the biological infrastructure that sustained the global COVID-19 rollout. When the virus forced a bet against the clock, their wager paid out. Right now, somewhere in Lagos, a woman is taking her daily dose of this medication. At that exact same moment, a child in Nairobi is swallowing a malaria tablet. This chart illustrates a massive pricing gap. If you look at the cost of a specific cancer treatment, a drug that costs $2,600 a month to manufacture in Switzerland drops to an astonishing $17 when produced in India. 9 times out of 10, when someone fills a prescription for a generic medicine, it comes from India. This is the result of a 50-year deliberate industrial push to make medicine cheap and accessible on a global scale. This map tracks where those drugs actually go. When you look at the United States, where the vast majority of prescriptions are for generics, 40% of them originate in India. Globally, 80% of the antiretroviral drugs used to combat HIV and AIDS flow from Indian suppliers, alongside roughly 60% of UNICEF's vaccine supply. To output that kind of volume, you need incredible physical infrastructure. The Indian pharmaceutical sector exports over $30 billion in medicine a year, sustained by a sprawling network of 10,500 manufacturing units. The modern health infrastructure serving both the wealthiest and the poorest nations relies entirely on this single pillar. If this supply chain were to suddenly disappear, the global medical system could not function at its current cost. But that massive scale brings persistent problems. Over the last 2 decades, international regulators have repeatedly cited Indian manufacturing facilities for severe quality control deficiencies. The most serious cases involve the actual falsification of safety data. In 2013, Ranbaxy, once the crown jewel of the industry, was forced to pay a $500 million fine to the U.S. government for systematically manipulating test records to hide manufacturing flaws. These flaws stem from how the industry was built. The business model relied entirely on reverse engineering, taking drugs discovered elsewhere and figuring out how to mass produce them cheaply. They mastered manufacturing, but they invested almost nothing in discovering new medicines. This chart reveals the resulting innovation gap. India's entire pharmaceutical sector spends roughly $2 billion a year on research and development. Compare that to the U.S. industry, which routinely spends north of $100 billion annually. Beyond a lack of original drug discovery, the industry faces an immense structural risk regarding its raw materials, what are known as active pharmaceutical ingredients, or APIs. These are the basic chemical building blocks required to synthesize any drug. Today, a massive 60% of those vital chemical building blocks are imported through a direct pipeline from China. Relying on a primary geopolitical rival for the basic ingredients of survival creates a vulnerability the Indian government has been painfully aware of since the 2020 supply chain disruptions. The country built one of the world's largest industrial empires by copying chemical formulas rather than inventing them, leaving it highly exposed to international supply shocks and narrowing profit margins. To secure its future, the industry is moving past basic chemical synthesis. Indian manufacturers are now building sterile production lines to create medicines from living cells. These are called biosimilars. They are highly complex, affordable alternatives to the extraordinarily expensive biological drugs used to treat severe conditions like cancer, diabetes, and autoimmune diseases. Corporate leaders like Kiran Mazumdar-Shaw have already established significant biotechnology facilities through companies like Biocon, successfully exporting these advanced therapies into strictly regulated Western markets. To support this transition, the Indian government has committed $2 billion to upgrade national pharmaceutical institutes into genuine research hubs. Over the next 2 decades, the goal is clear. India is racing to transform a massive industrial base that survived by copying existing formulas into an industry that invents original cures. To understand why this massive scale was built in the first place, you have to look back to a child with tuberculosis in 1955. At that time, a known cure existed, but the child died because the foreign company holding the patent priced the medicine far beyond what a local family could pay. Medicine was treated as a luxury good. Compare that scarcity to the reality today. Millions of people have access to well-stocked shelves filled with affordable, life-saving treatments. This shift began decisively with the Patents Act of 1970. India made a controversial legal choice to prioritize widespread public health access over the strict patent monopolies held by Western corporate interests. The policy carried a very specific mandate. As Prime Minister Indira Gandhi stated, the driving philosophy was that there should be no profiteering from life or death. That mandate is why Indian generics now make up 40% of America's prescription drugs. It is why their vaccines protect over 60% of the world's children today. The Indian pharmaceutical sector battles serious R&D gaps, supply chain dependencies, and a history of quality control failures. But beneath those deeply real challenges lies a massive industrial engine, explicitly built to serve the people who need medicine the most and can afford it the least. And because of that initial moral purpose, millions of people around the world are alive right now.